So hello, everybody, and thank you for joining us for our monthly Grand Rounds CME. I'm delighted to be here and delighted that you're all here. My name's Kim Dennis. I'm the Chief Medical Officer and CEO of SunCloud Health. We are based in Northbrook, Illinois, right outside of Chicago, and have centers throughout the Chicago area, as well as PHP IOP center in Gaithersburg, Maryland. We offer adult and adolescent programming for complex co-occurring psychiatric multimorbidity, really. It's no longer comorbidity, but we specialize in treating people with co-occurring addiction, mental health, eating disorders, and trauma-related disorders. We have 2 residential units. One of those is a general unit, and then another unit is specifically for patients with co-occurring eating disorders and addiction. I'm delighted to introduce the topic today, in part because one of the things we have offered for about the last year and continue to offer more and more of is interventional psychiatry, where we offer TMS as well as esketamine. And there's just so much emerging in the psychiatric space right now on treatments for PTSD, very, very hard to treat, and treatment-resistant depression. And I was delighted to reach out to Dr. Noah Phillip, who responded. I've been following Dr. Phillip's research in the TMS space over the last 5 years or so, I'd say. And after reading there was a new paper that Dr. Phillip published, I believe on Monday in JAMA Psychiatry. So when we talk about cutting edge TMS, treatment-resistant depression treatments, there's no better person to talk to right now, I think, than Dr. Phillip. So let me tell you a little bit about him. He's a professor of psychiatry and human behavior at Brown. His clinical and laboratory work is at the VA Providence, where he is the lead for mental health research at the VA Center for Neurorestoration and Neurotechnology. He's the founding director of the Psychiatric Neuromodulation Clinic there. Dr. Phillip received his bachelor's from McGill University and his MD from Albany Medical College, where he graduated Alpha Omega Alpha, and with a distinction in the study of biomedical ethics. He completed his psychiatry residency training at Brown, followed by T32 and neuromodulation fellowships, also at Brown. His career goal is to design, develop, and deploy neuromodulation treatments for PTSD and depression. He's active in several national organizations, including active roles in the Society of Biological Psychiatry, American College of Neuropsychopharmacology, and Psychiatric Research Society. Dr. Phillip is passionate about training and mentoring and is committed to action to improve diversity, equity, and inclusion and belonging. A believer in work-life balance, in the summer you can find Dr. Phillip wing foiling in the Rhode Island Bay, and in the winter, ski patrolling in the mountains of Vermont. So without further ado, I am going to hand it over to Dr. Phillip. Just delighted and thrilled that you're here today and can't wait to hear your talk.
Great. So thank you, and I'm really appreciative of the invitation and the warm introduction. So let me get started. So this is me coming to you from Brown University and the VA here in Providence. So I am a psychiatrist, first and foremost. I do lots of research, sure. I did not come through the standard research path. I really started a standard psychiatry residency and then realized that in order for me to help my patients as best as I could, I needed to be a researcher. Have been so since then, hence the 2 different fellowships that you heard about, so trying to catch up. So before I go on, I just want to remind you of some disclosures which are here. There's really nothing that is relevant to what we're going to be talking about, but I do want to highlight we're going to be talking about some off-label uses. There'll be some on-label use too, but certainly some off-label use and even investigational use. as we get forward. So, so what are we going to be talking about in the next hour or so? Well, so here's an outline. I'm going to start talking. Well, what I'm going to do is I'm really going to walk you through 3 different technologies. We're going to be moving from things that are used right now in the clinic, and talk a little bit of the use of transcranial magnetic stimulation. And we're going to move increasingly, if you will, experimental. So we'll then talk about our use using another kind of stimulation, transcranial direct current stimulation, which I'll unpack for you later. I will actually go into fair bit into this piece that we just had out in JAMA Psychiatry, because I think it's important. I think it has a number of very important lessons. And then I'm going to end briefly on some of our research in low intensity focus ultrasound. And I really introduced that really just so folks can have an idea of the technology space. Because really what we're doing is we're trying to put our heads together. We're trying to leverage the best aspects of neuroscience and psychiatry and psychology to help our patients get better. And speaking of which, so this backdrop is Providence, and this is water fire. It's one of our things that we do over the spring, summer, and fall, where we light up the little rivers that we have in our cute little town. This is our salute to veterans, and since I am at the VA, I always like to start with that. So, by way of introduction, so the illnesses that we're going to be talking about really need very little introduction, I think, to this crowd. So depression, PTSD, all their related things that come along with it, these are terrible illnesses, and they rob people of their lives, not just in terms of death and suicide, but also in terms of impairing people's ability to live the lives that they want to live. And I think also, probably in speaking to this group, when we think about the mainstays of treatment that we have for our patients right now, I think we can all agree that they just don't simply meet our needs. These, of course, include the medications as pharmacology, with reasonable degrees of efficacy, but also significant side effects. And also the psychotherapies that are out there. And again, great efficacy, but difficulties with access and also some with side effects that we don't often talk about in the psychotherapy space, particularly when we're talking about trauma-focused psychotherapies for PTSD. So within this context, I have been thinking a lot about other ways that we might be able to help people, really now over the last decade and change at this point. And so I'm going to start with transcranial magnetic stimulation. And just for reference for folks, I expect that there are probably some in the audience who are familiar with these technologies in different forms. I'm really going to walk you through each and every one, and I want you to sort of bear with me if you know this stuff already. I think it's just important for us all to have the same conceptual framework as we go through and discuss what they are. So what is transcranial magnetic stimulation? It is helping people with high school physics. So we're going to take a rapidly fluctuating magnetic field, and we're going to use that to induce electrical activity within a conductive media. And it just so happens through this bizarre, I don't know, coincidence of evolution that we have an ideal conductive media between our ears. So this is Faraday's law, and there's Dr. Faraday with a little quotation that I'm particularly fond of there. And so now, unlike the meds and unlike the therapies, we're going to be talking about technologies. And so bringing up technologies means there's other questions about their application that we need to answer before we even do them. And the first question I'm going to pose to you is, so where are we going to put this device? So where should we put our TMS coil? And you're going to notice I'm saying in parentheses depression, because I'm going to tell you a story about depression. And you're going to see, I suspect it's a bit more of a story than we realize. So this is a PET scan for the 1980s. You do not need to be a neuroradiologist to see that there is something different in the brain of a depressed individual. Fast forward, if you will, to the modern era, where now what we understand about depression, about post-traumatic stress, and actually about many of our other psychiatric illnesses, that really they reflect large-scale dysfunction in what we'll call our functional neural networks. So different parts of the brain that have to be working together in a particular way for the brain to function in a healthy way. So this has been demonstrated time and time again in terms of depression. There's lots of different areas, there's lots of different connectivity profiles, which I'm not going to go into too much specifics today. But these need to be working. And when they don't work, we have illnesses emerge. And as the story often goes, we start in depression, something very common. But then as we use our more advanced neuroimaging tools, we start to see that the same story applies in other areas. And so, for example, in post-traumatic stress, and I'll introduce very briefly 3 different kinds of neural networks, right? Regions of the brain that need to work together to do a certain thing. And we have a default network, which is involved in introspection and thinking and memory, if you will. We have a salience network, which is involved in figuring out what is relevant to the world around us, and an executive network, which I'd like to very briefly sort of think about as kind of our willpower network. It's really regulating what's going on. And in PTSD, what we have is we have an illness where people find the world to be more threatening and are often sort of stuck in terms of their internal thoughts on the process and about themselves, and are not able to regulate that process at all. And with a little bit of anthropomorphizing, what we see is these neural networks are telling us exactly what our patients are telling us. And I think that's a very helpful framework to think about some of the advanced neuroscience and see how it's relevant. And furthermore, it's really relevant because it helps us answer the question, where are we going to put this coil? Because the common feature in all of these illnesses are problems in the dorsolateral prefrontal cortex, or part of the executive network. And let me show you how that matters for TMS. So this is a SPECT scan, a SPECT study actually from some of our colleagues in Japan, a little bit dated at this point. So this is showing changes in metabolism over time, comparing people before they get stimulation and after stimulation, looking at the dorsolateral prefrontal cortex. And those red blobs mean that there's an increase in activity in the targeted area. And so you can say, hey, well, that's great. So we can change how the brain is working when we put the coil on top. What's also really neat is that when you ask what changes in the brain when someone gets better, what we see is not just change in the targeted area, but we see a change in many other downstream areas. So polysynaptic signal transduction, that's got to happen for people to get better. And by the way, I'm going to show you some work from my group and otherwise, but this is one of the most highly replicated findings in psychiatric neuroscience and brain stimulation, is that we can change something locally, but in order for people to get better, the signal's got to go all over the place. So we have a target. That's our dorsolateral prefrontal cortex. And now we've got to figure out how we're going to calibrate our device to each person, because everybody's brain's a little different. And so at this point, we don't quite have an idea of how much energy it's going to take for an individual's brain for the neurons to fire in the way we want them to fire. We're not quite there yet. But what we can use is a proxy for this, and that's looking at the motor cortex. And this is an image, me training one of my colleagues how to calibrate our device or perform what's called a motor threshold determination. And so what we're going to do is we're going to figure out how much energy it's going to take when we stimulate over the motor cortex and elicit movement in the contralateral hand. And I want to not just tell you about this, but I want to show you in the next video what this actually looks like. And a little moment of truth where hopefully the sound will come through on the video. And maybe Dr. Dennis, I'll ask you to give me a heads up if you can hear it. And if you can't, I will simply narrate, and that'll be okay too. So here we go. All right, so we're going to be demonstrating a motor threshold, and Travis is very generous this time. So what I've done is I've placed the coil over his motor cortex and over the part of the homunculus that corresponds to his right hand. And so what I'll do is, I want you to put up your arm, Travis. And I'm going to deliver some energy, and what we're going to be doing is watching for any movement in his hand right here. So here's a pulse. And what you can see is movement in his first finger. I should also add, what you can also see is we are clearly no Hollywood producers, but what you can see is movement in that finger, right? So that is our index of polysynaptic signal transduction that gives us a proxy or an idea that the energy is flowing where we want it to flow. And what's really neat is this is precision psychiatry. We're using an individual dosage based on someone's brain and what their brain is telling us. And so what we do is we take that energy, we increase it up to 120% of that energy. And the standard treatment at this point is 6 weeks of daily treatment to the dorsolateral prefrontal cortex. We started our treatments at 37.5 minutes every day. We can now get it quite a bit faster than that. I'll come into some questions about accelerated TMS. Can we do lots in a single day? For the technically interested in the audience, we're giving about 1.5 Tesla when our maximum output. It's generating about 100 volts per meter of brain. And it's an outpatient procedure with no systemic side effects. So people come in, they get their stimulation, they go home, work, school, kids, whatever it is. And there's really no, I mean, part of what attracted me in this first place also is that there's no sexual side effects. There's no weight gain. There's no diabetes risk. There is none of that because no one is taking a pill. I don't want to be too Pollyannish about it. Every time we stimulate the brain, there's a risk of someone having a seizure, but it's a single isolated seizure, and the incidence is extremely low. So really good safety profile. So, and we have seen, and Dr. Dennis and I were talking a little bit about this before we started, we have seen tremendous advances in TMS in the last couple of years, and I'll walk you through just a little bit of history in literally one slide. So we are now a chunk of time away from the original randomized controlled trials that showed that active stimulation was better than sham stimulation. So, back in 2007 was the first pivotal trial that was published showing that TMS worked. And then fast forward, it took actually nearly a decade, a little bit over a decade, for a second generation form of TMS to come out. This is called theta burst stimulation, which has a lot to it. But one of the things that it does is it allows us to deliver large volumes of stimulation in a very short period of time. So what would have taken 37.5 minutes, its non-inferior equivalent now takes 3 minutes. And 3,000 pulses to 600 pulses. So a higher dosage or concentration of energy. Then really in the last couple of years, some work from Nolan Williams and colleagues and good friend over at Stanford University published the Stanford Neuromodulation Therapy Trial called SNT or SAINT, depending on which publication you're reading, and essentially using large amounts of energy in a single day, delivering accelerated TMS and getting people better. It's neat. It's early days yet in terms of the data supporting that use, but it's very exciting. But there are also a lot of questions that are out there right now. And namely among them, just to highlight a few, is really how are we going to target this? Are we going to be measuring from the motor cortex? Can we take a series of skull-based measurements? Do we need to do something expensive or specialized as functional connectivity targeting, which is a substantial logistical lift? And that Elbow et al. Paper in the sort of bottom right really raised a lot of questions about the utility of the functional connectivity targeting, what it was actually contributing. So I think there's a lot that's out there. It's really exciting, and it is moving very quickly. So our story, I'm going to shift a little bit here, is really about transcranial magnetic stimulation and its use in post-traumatic stress disorder. And I've been doing this for some time now. We started sort of in the earlier days looking at maybe novel frequency parameters or device settings or newer devices that we might use to sort of customize and match the stimulation to see if we can get people better. We've also done a number of biomarker studies, so asking what are the relevant changes in the brain that happen when people are stimulated? How do we understand when their brains get better? And then what are some of the predictors? Is there a neuroimaging or maybe an electroencephalography profile that might help us identify or stratify those people most likely to respond or not respond? And certainly using theta burst, really, we were doing accelerated theta burst before we knew that it was accelerated theta burst. Really using that in PTSD and seeing not just to get people better, but making sure that they were staying better over time. I like you heard in the introduction, I run a neuromodulation clinic. The people who come to me are treatment resistant. They failed many things. It's all well and good to get them better, which is what I'd like to do, but it's equally as important to keep people better. So, and just in terms of just to talk about some sort of network dysfunction and brain changes, and then from here on out, there won't be too much neural network stuff. What we can see, though, is we can see some interesting predictors of response. And I'll walk you through these images here because one of them is going to be relevant in a bit. But what we can see is that so this is a brain, by the way, in case it wasn't obvious. We've cut it in half, and I want you to imagine that we've taken a straw and we've plugged it into the brain and blown into it. So all those gyri and sulci have essentially expanded out, so you can sort of see around the brain. Blue colors represent reductions in functional connectivity or communication between areas. Warmer colors represent higher connectivity or increased connections. And the seed or the area I'm looking at is the one that's listed. So the subgenual anterior cingulate, this is involved in a lot of things, is certainly predictive of response. And what we also have seen is that those individuals who have a tighter coupling between their prefrontal cortex and their amygdala really do much better with TMS. And this is a story I'm going to ask you to sort of throw in the back of your head because I'm going to come back to this in a bit. And I think in the interest of time, I'm going to largely skip over this, but what we also see, as you saw in the slides before, is that we really see the brain reorganize itself substantially when it gets better. And one of the really cool things that we see, and drawing your attention to that hippocampus there for a second. So what this is asking is, how does the connectivity of the hippocampus change after people get better? And the blue line there, or the blue blobs, if you will, that you can see are in the anterior insula. This is part of the salience network. It's involved in threat processing. And so what we see when people with with PTSD, I'm sorry, get better after stimulation is we see a reduction or a disconnection between memory and fear circuitry and salient circuitry. And so I think, again, with a little bit of anthropomorphizing, it starts to sound like what people are telling us when they get better. So let me shift a little bit into sort of real world use of TMS at really this intersection of PTSD and depression. And so a couple of years ago, we sort of asked the question about, it's all well and good. I showed you, rarefied, clinical trial patients and all the prior slides, and that's all well and good. But I think we all can recognize that our treatments actually have to work in real patients. So we started the National Clinical TMS Program. This is Dr. Michelle Medor, who is at VA Palo Alto, who is the director of the program and with whom I've been working very close and sort of helped set up the program in the first place. Like I said, VA Palo Alto. And we have now about 60 some odd clinics across the nation. We are hoping that someone in Alaska, someone in U.S. Virgin Islands, and maybe Guam will want to start a clinic so we can go there and help set them up. Particularly in a nice time of year. But anyway, this allows us to start looking at really large scale outcomes of TMS in the real world and ask, does this work for real people? And the short answer to that is yes. So here what you're looking at are depression scores, that's the PHQ-9, looking from pre-treatment to post-treatment. On average, this is this was the first 770 people who came through the clinic. And what we see is a substantial reduction in PHQ-9 scores. Does it go down to 0? No, it does not. But it's a substantial, clinically meaningful, and certainly statistically significant reduction. And for those people who like effect sizes, that's a Cohen's d that I've included there, which is very large. And what we also see is that so all well and good. We can get depression better. We kind of knew that we would, or hoped anyway. And what we also see is a very, very large reduction in PTSD symptoms. And here we're looking at the PTSD checklist for DSM-5. So a very standard self-report checklist that's easy to do. Again, very large effect sizes, and a 20-point reduction is very clinically meaningful. And what I should also say, and it's not in the slide, is actually nearly 60% of people no longer met PTSD criteria after they were stimulated. And that's a really, really good outcome for these patients who are often very difficult to treat. And let me, I'm going to answer a couple of things that are going to come up in the Q&A, so I'm just going to get ahead of it. One of the questions I always get is, well, PTSD and depression, they all overlap, their criteria overlap, there's mood and cognition and PTSD and all the ways in depression, and how can you ever possibly disentangle them? And the answer is, with a big enough sample size, we actually can. So what we actually see is when you quote unquote control for depression and things like that, or PTSD, what we see is that they're actually operating independently. So we really can be confident that the depressive symptom improvement is real and the PTSD improvement is real, and one is not really informing the other all that much. Perhaps not surprisingly, we find that those individuals with PTSD, of course, have higher scores. So the people with this comorbidity or multimorbidity are sicker. That's no shock. And then, but perhaps to my chagrin, as someone who has published a lot about trying to find an ideal stimulation paradigm for PTSD in particular, we really could not find that any particular device setting made any difference. No particular device made a difference either. What really seems to matter is getting energy into the brain And then honestly, a standard course of left DLPFC TMS works magnificently for PTSD when it's comorbid with depression. A few other sort of whatabouts, a little bit more recent work. I work in the VA, so we have a lot of TBI patients. I would challenge all of us who work with civilians as well, or non-veterans. You have a lot of TBI patients as well, unfortunately, but we don't often think about it. And I had thought that individuals with TBIs would not respond nearly as well. I thought there would be subtle injury in their white matter and various other things, and I was completely wrong. So we did analysis of this is about 500 individuals per group, and what we basically found was that those individuals with traumatic brain injuries did just as well as people with without traumatic brain injuries. And also no sensitivity to like the number of brain injuries over time or otherwise. So we can be, bad for my hypothesis, but I think really good for patients. That when they have things that are really problematic for them, we can still say, hey, listen, this can work for you. The other thing is that in the early days of transcranial magnetic stimulation, it's still out there in a lot of the CME items. We found that TMS appeared to not work as well in older individuals. And that was with really small sample sizes in the original registration studies and a little bit beforehand. And so we looked at this in our very large cohort. And what we actually found, and this is on the left-hand side, is sort of a post-treatment score by decade, and then looking at younger versus older people in terms of their depression on the right-hand side. What we found was that older, and it's gonna pain for me to say this, but older was here defined as 50 and above. You can tell how the age of the postdoc who was doing the analysis. But people over 50 did much better with TMS. So the average score in this large cohort was at remission if you were over 50. So it's 5.01 with a score of less than 5 being remission on PHQ-9. That's really good. And so again, I think this provides a lot of hope for many of the patients that come in. The younger patients are still doing well, but actually the older patients are doing even better, which is kind of neat. And I think most importantly, right? So what do patients make about all this? And I'm going to show you in his next video. This is going to be Bill. He's going to be one of my patients, and he has given his permission to share this video with you.
After the fourth or fifth visit, I noticed there was a difference. There was a big difference, and my wife noticed it too. She goes, "You're a different person," and I felt like a different person. I could cope, I could manage, I could just.
And what I also really appreciate about what Bill says here is that he's focusing not on the rating scales that we follow in research studies and whatnot. He's talking about what this is doing for his life. And I think it's really important to listen to that. So with that, and we're good on time. So excellent. So with that, we're going to switch, and now we're going to move from things. So now from previously, we've talked about what you can get right now today in a TMS clinic. And now we're going to move into increasingly more experimental things. So now we're going to sort of get into the, a little bit more experimental work. And so here we're going to start talking about transcranial direct current stimulation for PTSD. And so just to start, I know I promised no more neural networks, but I actually lied because I can't help myself. So one of the things that we keep seeing in our work and in others is that the ventromedial prefrontal cortex needs to work for people to get better from PTSD. We've seen that. I showed you some of the ones that you saw that sort of top left previously. I've seen it in other of my studies that we have published. And those of us in the PTSD space, whenever we think about the medial prefrontal cortex, we start getting very excited, because that's the area that's involved in extinction learning. And what extinction learning is sort of the neurobiological process that's involved in exposure therapy. So that's the key region of the brain that has to be working. And let me walk you through a few sort of pieces of that, just so that we know what we're talking about together. And so I want you to think about really as you can consider PTSD really as a disorder of memory. Right. So veterans, in my example, will learn that a particular context is unsafe. So there's a marketplace, for example, and they learn this context is unsafe, and they learn this again and again and again. And this learning is incredibly adaptive, right? This keeps them alive, and it keeps their friends alive. Their challenge is that then when they come home or they come out of that context and they come to something that is, I'm going to say, vaguely similar, they then have to learn that this environment is now safe. That process is called extinction. The ventromedial prefrontal cortex needs to be working for that process to happen. And veterans essentially with PTSD really can't learn that this new market stateside is safe. They're failing to extinguish. And one of our challenges is that we can't, at least not yet, we can't get TMS into that ventromedial prefrontal cortex for a variety of physics reasons, which I can get into in the Q&A if people are interested. So we started using a technology called transcranial direct current stimulation. And so what is that? So here we're going to take a person. This is loosely modeled after me when I was clean shaven. And we connect them to a power source, typically 2 milliamps, or roughly what you can get out of a 9-volt battery. To that power source, we connect an anode. That's where electricity is going into the brain. And then a cathode, where electricity is coming out of the brain. And what we've done here is we've created just a very, very simple circuit, introducing electricity into the brain, which then prompts us to ask, well, but how can just a tiny little bit of electricity be helpful? How can it do anything? And to answer that question, I'm going to have you imagine a couple of different neurons in the brain, if you will. First, we're going to have some quiet neurons. They're hanging out in the background. They're not really involved in what we're talking about here. And then we have some other neurons, and these are ones in the medial prefrontal cortex that have some degree of endogenous brain activity. So they're working to some degree, but simply not enough. So that dotted line is the membrane threshold potential, the sort of energy over which the cell needs to go in order for it to depolarize. And now you introduce a tiny little bit of electricity into this system. It doesn't really do anything to the quiet neurons, getting transcranial current stimulation. But these other ones in the ventromedial prefrontal cortex, we can help them to fire when they otherwise wouldn't. And here we're essentially inducing plasticity, right? We're teaching the brain or the neurons to fire when they otherwise wouldn't. So now what we have to do is we have to figure out how we can get this electricity. So we've got this effect, but how do we get the electricity where we want it to go? And to answer that, what we do is we take a number of ways to do it. But at this point, we take a person and we take maybe an MRI scan that they have. And then in silico, in a sort of a simulation space, we put that anode and that cathode in a number of different places. And we ask, where's the best fit? And this ends up looking something like this, where warm concentrations or higher concentrations of electricity. Again, this is like 2 milliamps, this tiny little bits of electricity. But you can see we can get energy in that ventromedial prefrontal cortex in the area where we want it to go. It's not extremely precise, but it's hopefully going to be good enough. We'll see. So now we have to start thinking about the context in which the stimulation is happening. Remember, so this energy is requiring on some degree of endogenous brain activity. And so working with Dr. Masha Frank, who's been a good friend and colleague really for the last decade and change, we did a series of experiments. We're trying to figure out if we can enhance this extinction with transcranial direct current stimulation. So in this picture, there's me, and I'm looking at a computer screen. And in this example, there's lots of things. So I have a TDCS set up on my head. You can see the cathode, that's the blue sponge there. And then you can see on my left hand, I am wearing some skin conductance electrodes. That's measuring how sweaty my hands might get. And then on my right hand, I have what I'm going to call a shocktrode, which means something that's going to give me a zap. And in this paradigm, what happens is I'm looking at it, and every time I see a blue lamp, I get a shock. And I'm going to see a blue lamp again, I'm going to get a shock. So blue lamp, shock. And sooner or later, every time where I see that blue lamp, I'm going to start to sweat because I know what's about to come. And then what we do is we move forward. We actually show me a blue lamp, but I don't get shocked. And the amount of time it takes for me to figure out that the blue lamp is no longer dangerous is an index of my extinction. And what we showed is that we can accelerate this extinction process in healthy controls and in individuals with PTSD. Now, the challenge here is that patients don't come into my office complaining about blue lamps, right? So they come in having gone through horrific things. I put up a military picture here, but it's just as often with non-military trauma. But people come in just profoundly ill with their PTSD, really suffering from their lack of extinction, if you want to sort of call it that way. Now, I can't put people back in a war zone to learn that the war zone is no longer dangerous, right? That's not ethical, not possible, not otherwise. But we do have this wonderful thing called virtual reality, right? Where we can put people where they can't go or where it otherwise wouldn't be safe to go. And really to manipulate that context that we're talking about here, that's going to be so important. So this is what our setup looks like. It's a BraveMind setup by Virtually Better. It's a standard off-the-shelf system and setup. Both these are two different staff members, and Steve to your left is wearing a VR headset. This is, by the way, is a very immersive VR system. So it includes visual input, of course, auditory, so you're going to be hearing things. He's sitting on a rumble strip, so there's haptic feedback. And actually, there's olfactory feedback as well. There's a little smell box in front of him. And so in this next video, I'm going to have you imagine that you're picking up the VR headset and putting it on so you can see kind of what we do in the virtual reality before I describe a little bit more about what's going on. So here we go. So in this video, it's as if someone is in Iraq or Afghanistan. They're on a patrol or a convoy or otherwise the vehicle in front of them hits an IED and explodes. So what we did to start off with here is we first conducted a little pilot trial, 12 people, with lots of lived experience in the military. And we did a number of different things in the study. So they came in for a baseline, and then we basically gave them 1 week to start, 3 sessions of this TDCS plus VR or sham stimulation. And then we repeated the same thing in a second week. And this was largely based on other virtual reality exposure studies that have been out there. And then we had people come back 1 month later to see how they were doing. So very, very simple experimental design. We published in Brain Stimulation a couple of years ago. And here, what I'm going to show you is some of the skin conductance and what that looks like. And so the little arrows up top are the things that are happening in the virtual reality. The red line is a tracing of someone's skin conductance or the sweatiness of their palms. And you can see that they're very, very jagged as they react to everything in the VR environment. After 2 weeks or 6 sessions of TDCS plus virtual reality, they start looking like this. So people are still reacting, but not nearly as much. And what we found was this was a process that was happening much, much faster in those individuals who got active stimulation. And that interestingly, when they came back a month later, this wasn't statistically significant, but their symptoms kept getting better even after they were done with this combination. And that was really interesting. And we didn't know what to make of it. So being the good scientists that we try to be anyway, we did this whole thing again. So we went to the U.S. Department of Veterans Affairs, got a large grant, and did this in a randomized controlled trial. Except in this case, what we actually did was we added a 3-month follow-up because what we had seen, right, is an emergence of some initial improvements at 1 month, and we thought maybe 1 month isn't long enough. And so, as you heard, so this was published earlier this week in JAMA Psychiatry. So it was 54 individuals, heavily skewed men because we're at a VA, and sort of a middle age, and everybody with chronic PTSD, with war zone trauma. I will say other traumas were not exclusory. And matter of fact, if you go to the supplement, you will see, unfortunately, the wide range of terrible things that happened to individuals that had nothing to do with the military. Our intervention, as you heard, was a combination of transcranial direct current stimulation, or a sham version, plus virtual reality. And our primary outcome measure was change in the PCL5 at 1 month. And that decision was informed, of course, by what we saw, where people were still getting better afterwards, after they were done with the 2 weeks. And what did we find? We found that this combination was extremely effective. So this is statistically significant improvement, a large clinical effect size, and really favoring active stimulation over sham over time. So the virtual reality still works, right? The sham group is still getting VR. So VR is actually quite effective. But here what we're doing is we are profoundly accelerating the course of improvement with this combination. We didn't find that this cured everything. Matter of fact, these effects were pretty specific to PTSD. So this is our depression rating scales over time. You can see there might be some indication that people are actually getting better in their depression at 3 months in the active group, but we don't really know. And I should say, sorry, the darker color is the active group. And as we were starting to observe in our pilot study, we actually found that people's quality of life, and I shouldn't say quality of life, their social and occupational function, pardon me, really was better at 3 months, whereas it was all kind of the same going through, and that was highly statistically significant. That said, our primary outcome measure was 1 month, so take the 3 months with a grain of salt. And I should also say there was this was conducted, of course, during COVID. So our attrition, at 3 months later was very, very high, as both patients, staff, systems kept shutting down, opening, shutting down, et cetera. So that was unfortunate, but that's the reality. And I showed you the skin conductance earlier. And so what I used to do before the study was done, I would say, like, well, we've got 2 groups and they've got some skin conductance. We've got a group A that's pretty jagged and a group B that's pretty jagged. After the 3-week intervention or 2-week intervention, pardon me, we have one group that seems to be just as reactive as they started. And we have another group that's not, much exactly like we saw in the pilot study. And luckily for us, right, this turned out to be the active group with the large reductions in arousal, right? So this is pathological arousal that's gotten better. And that was a sham group. And so here what we have, and just as I start getting towards wrapping up about this, what we see here is a combination of subjectively reported improvements. These are the rating scales, and an objective measure of people's autonomic activity, their hyperarousal, that is also getting better with active stimulation. So we're very proud and excited about this work. It does represent, a decade's worth of different experiments and studies and some incredibly good collaborations with wonderful colleagues. I forgot to say, yes, this is all highly statistically significant. The other thing I'll say, and maybe actually in the interest of time, I'm going to largely move over this. Oh, I see I am blocking Amanda's picture. That is no good. Hold on one sec. I'm just going to move this. We do have some interesting connectivity work that is not quite ready for prime time, but it's okay enough to share. Where what we actually can see, there we go. Yep. So we actually can see something very similar to what we have seen in some of our other studies. So connectivity from the ventromedial prefrontal cortex to the amygdala is predictive of symptom change, which is neat. The other thing that we're seeing maybe is that when people get better, their connectivity profiles are also changing. And again, I think this is giving us a more objective measure that their brain is in fact getting better when they say they're getting better, which is good. Okay, and we are fabulous on time. Good. Okay, so in the last 15 minutes, I want to introduce you to low intensity focus ultrasound. So again, as a reminder, we've gone from things that can be used clinically to efficacy studies that are showing, with fairly standard off-the-shelf devices. And now, as a reminder, we are going into investigational use only territory. And so here we're going to be talking about ultrasound. So our physics, by the way, are also incredibly changing. So up to now, we've talked about essentially magnetism and electricity and otherwise. Now we're talking about acoustic or mechanical energy. So totally different part of physics. And so ultrasound is defined as generally sound that's above human hearing. Typically, it's around 20 kilohertz. I think we all are used to thinking about ultrasound from a diagnostic perspective, right? We're using broad and unfocused beams to look at shapes inside of shapes, where the sound is bouncing off of things, and we reconstruct it to develop a picture. And that's not what we're going to be doing here. We are really going to be thinking about, can we use ultrasound in the same amount of energy that we use for diagnoses? Can we use that for neuromodulation? So why would we do this? Well, because it's going to be more precise. So transcranial magnetic stimulation has a focality roughly 2.5 to 4 centimeters. Transcranial direct current stimulation, you saw the electrical field maps. There's lots of red and blue and whatnot everywhere. We can get it where we want it to go, but it's definitely not precise. And here what we're talking about is we're talking about a focality that might be on the millimeter scale and certainly small centimeter scale. And I'll actually show you some of that later. And so this has the promise of non-invasive and focal deep brain stimulation. And if this pans out, and I really emphasize if this pans out, this is a game changer in terms of what we can do, because many of the brain areas that are involved in not just PTSD and depression, but substance use and otherwise, these are deep, deep in the brain, and they are very small. So it's very, very exciting. And for those of you, if you want a quick little read, I put out a little sort of hot topics, like a 500-word sort of, I don't want to say it's a soundbite, but a very easily digestible intro to low-intensity focused ultrasound in neuropsychopharmacology. I want to say it was last year, 2022, 2 years ago at this point. But good for further reading. So what are we doing? We are trying to turn off the amygdala. Using low-intensity focused ultrasound in patients who have depression and anxiety. So this is a study where we are trying to evaluate. We have three main aims, I should say. And the first and foremost is safety and tolerability. This is work that's supported by the VA from a research perspective. It's overseen by the U.S. Food and Drug Administration, so it's a first-in-human application. And is funded by the National Institutes of Mental Health. This also means that I exist at the intersection of 3 different federal agencies, which is an interesting place to be. But you know, it's exciting. So that's what it is. And our hope is that we can turn off the amygdala. And you might ask, well, the amygdala is involved in a lot of stuff. Is it really just involved in depression? And the answer is, of course, no. And I chose the amygdala as a target because it's involved in everything. And if we certainly, as a proof of concept, can reduce the amygdala or turn it down at the very least, that's going to have wide-ranging implications for depression, for anxiety, for PTSD, for substance use, for schizophrenia, for whatever have you. And it allows us to really meaningfully test if we can do this safely. So what does this look like? I'll show you. So here's Steve again. You may remember him because he was wearing the VR headset a couple slides ago. So this is outside of the scanner. He's where we're using a single element device, and it looks like a hockey puck strapped to the side of his head. So this is something that's very, very focal. So now this is a schematic of what the ultrasound transducer looks like. And it has a focal zone that's about 65 millimeters deep. And has sort of a broader sonication zone that's about no more than 30 millimeters long and 4 millimeters wide. So what it is a very, very small ellipsis or cigar-shaped area of neuromodulatory activity where the energy is essentially concentrated in a very, very small spot, but keeping the overall output of the machine less than what you would use for a diagnostic ultrasound, like a fetal ultrasound or otherwise. So hence the term focused. And you can say, well, that's just a tiny little bit of energy, and we use these, all the time. And how can that possibly use from a neuromodulatory perspective? And I would say that's a great question, and I'm going to show you. So in this next video, what we're going to do is we're going to put a transducer on a table. I'm going to put a cup of water over the transducer, and we together are going to look at the very middle of that cup of water on a standard setting. So just look right in the middle, and there's a tiny, tiny, tiny little movement in the meniscus. It's a couple millimeters wide and a couple millimeters high. And so this is even though this is the same amount of energy technically that's coming out of a diagnostic ultrasound, it is certainly enough to do something. And I want you to imagine, right, this is what we're actually doing to people's amygdala. So this is, again, acoustic or mechanical energy. We do this all under MRI guidance, and we do that for a number of reasons. So certainly the actually most important one is that we can immediately get a stroke quality scan as soon as the ultrasound is off, because we still don't know if this is safe. So this is please do not do this at home. It also allows us to make sure that anything we observe, we can observe in real time. This is what the targeting looks like. The circles on the left-hand side are a series of MR-related fiducials that essentially allow us to perform the ultrasound under MR guidance, as I mentioned. The blue line going across and the green line going across are sort of the line on which the beam is following. So what we do is we line up a series of perpendicular lines in three-dimensional space to intersect with the amygdala. And we often will is the beam going, and you can see that depicted there in blue. Again, this is some work spearheaded really by a just absolutely fantastic. She was a postdoc, now member of the faculty, Dr. Alpagasa. So this is a little bit like building a ladder as you're climbing it. So it's a first in human use. We are ongoing, or I should say the study is ongoing. I will not be presenting results here. The reason I'm not presenting results is because I really want to make sure that we do this carefully and thoughtfully and not get too ahead of what the data is. What I am comfortable sharing, however, is that at least to date, we have not had any serious adverse events, and those are defined as things that put people in the hospital or cause sort of serious risk to injury. But I also put a little ... because it's early days yet, and so one never knows. I also feel comfortable sharing at this point is that we definitely have a non-zero side effect profile. So this is something that we are following very, very carefully. The most common side effects are largely CNS, as you might expect, but it is definitely a non-zero side effect profile. And one of the things that we have is we actually have a structure where we have an unblinded safety assessment and then a blinded clinical outcomes, because we really want to make sure that we're capturing everything we possibly can. So stay tuned. It's probably still going to be another year or two until we're done with this, but that's okay. This is a slow and steady process, and we want to make sure that if we do find something that's useful, we can trust it. And if we find that it's not safe, that everyone knows, and that we really move in a different direction. You know, high intensity focused ultrasound is something you can get right now to ablate or burn, parts of the brain involved in movement disorders and otherwise. And that is really what we do not want to do. Really want to have something that is deployable. And certainly, as you may know, right, every primary care, not every, but many primary care offices have an ultrasound device. And this is something that could very quickly scale in a way that is currently impossible with transcranial magnetic stimulation or other existing technologies. Good. Okay. So what have we done here? So really, I've walked you through a number of different technologies, right, in different ways, really combining what I like to think of as the best aspects of neuroscience and psychiatry, really all in pursuit of helping people to get better, right? Starting with transcranial magnetic stimulation, which, as you are doing now, people can get. And some things that I hope are in the near-term future, things like this integrated stimulation and virtual reality, and then give you an idea of, again, what I hope is coming in the future with low-intensity focused ultrasound, although, admittedly at a very, very early stage. And just before I conclude, I'm the one giving the talk. I'm acutely mindful and incredibly grateful for a just absolutely stellar team, some of which are pictured here in Bitmojis, so that I don't put their pictures all over the internet and various other places. But I have an enormous number of colleagues, staff, funders, and otherwise, to which I'm just incredibly grateful. My email address is on the bottom. For those still using Twitter, which I have mixed feelings about, but I'm still on, my Twitter information is there. And I will wrap it up and use our remaining time for Q&A.
Awesome. Thank you so much.
My
Speaking
pleasure.
of teams, I'm going to introduce one of my team members here, Tammy Gazer, who will just tell anybody who's on right now next steps as far as getting your CME and CE credits, and then we'll launch into questions.
Oh, perfect. Well, hey, thank you so much. And Dr. Phillip, what a great presentation. I'm literally mind blown over here. I was trying to write notes and keep up with everything you were saying. So I'm really glad we're going to have this taped for you guys to have other staff, your other colleagues watch this later. I will be sending out an email today to everybody who has attended. It will give you detailed instructions on how to get your CE. If you have any questions at all, respond to that email from me, and I'll help you get everything taken care of.
Wonderful. Thank you so much, Tammy, for all of the background work to make this presentation possible and the CMEs and CEs possible. So I will I'd love to get into some questions and answers, and I have a couple already in the chat. I mean, also in the chat is just other people saying how mind-blowing the presentation was. So
Absolutely.
one of the questions is, you know, despite, and we run into this a lot in the real world, you know, with non-TRICARE, non-Medicare, Medicaid payers. Where are commercial payers with as it relates to covering TMS for PTSD?
Yeah, it's a
And
great.
what are the barriers? You know, the data is there, right?
Yeah. So the data is there, and that's part of why we've been generating the data. So one of the challenges with some of the commercial payers, I can just speak to the Northeast region because that's what we're doing. It's different, different payers in different places. And I should add, it wasn't here, but I mean, I was in private sector before I came over to the VA, so I understand what we're talking about, and I've spent an awful lot of time getting prior authorizations and peer review, and so I really appreciate where this question is coming from, because it's a main barrier of care for our patients, right? So one of the challenges is that in the early registration studies of transcranial magnetic stimulation, they systematically excluded anybody with PTSD. And oftentimes what commercial payers will do is, if they see that in exclusion criteria in a registration study, so a research study, they'll say, well, because these people were excluded, therefore we are not going to cover them. And that's a real problem. And you can get into lots of reasons why they might be doing this, but it's a real problem. And so part of, honestly, why we started this large scale registry data, I showed you data from 770 individuals. This is just like the first cohort that we have analyzed. We've got another like 1,000. I mean, part of why we did this is to show, because we can do this at VA, right? So we don't have to worry about commercial payers at VA, which we have all sorts of other challenges. This comment was not brought to you by the U.S. Department of Veterans Affairs. This is my own opinion. Anyway, we have our own challenges, but one of the things we don't have to deal with is we don't always have to deal with commercial payers. And so one of the things that we hope to do is be able to put literature out there so that when there is a commercial payer that says, no, we're not going to cover this, you can say, hey, look at like Philip et al. Or Mador et al. And whatnot. We can get a 20-point reduction in PTSD. Like, there's no other. I mean, those effect sizes, that symptom reduction is better than what you can get out of most of the gold standard psychotherapies for PTSD. And this is in real world people. With all the comorbidities that come with all of our wonderful veterans. I mean, everybody, substance use comorbidities, this, that, and the other, it's all there. So right. So I will say that our local commercial mix here in the Northeast is not so bad in terms of when there's an MDD and PTSD comorbidity. And that's largely what we published on. I mean, so I don't know, I didn't put up the numbers, but of the people, it's like a 68% comorbidity rate. So all the data I showed you was all people who have comorbid PTSD and depression. We have very few people actually who have just PTSD, and many of the people who just have PTSD, when you dig a little harder, you find depression. So that's how I would answer that in terms of the commercial payers thing, is that, they probably will say no, and you probably have to go back to them with some data to show that it is efficacious, right? So that's the word you want to use, is efficacious, not efficacy, right? And efficacy is sham controlled studies, and what you really want to talk about here is efficaciousness in the real world. There is efficacy data out there too, but you're not doing sham controlled work in patients. That's not the right bar. So I hope that's helpful.
Oh, wonderful. You touched on this a little bit, but I want to ask a follow-up question on it. You said there's no real data substantiating, greater effect, greater efficacy with different types of TMS machines, because there are, and each of them says theirs is the best, right? And each of them, unfortunately, also has different FDA indications, and insurance will say, well, we are not going to cover this because that particular machine isn't FDA approved for,
Right. And so, for example, right, the Brainsway group did a large randomized control trial where they gave TMS while also eliciting PTSD symptoms. And what that study showed was that people that active stimulation actually did a whole lot worse than people who got sham. And that's not the same thing as what we're doing. We do not we do not try to provoke someone's PTSD symptoms in the clinic.
Most patients don't need help with that.
Yeah. So what the data here is not that, and that's not really, certainly if you're going to talk to a commercial payer, really what you're talking about is just doing standard TMS. And what our data very clearly shows is standard left DLPFC works great for PTSD, as certainly when it's comorbid with depression. And each device is a little bit different. They all have their various different things. No, to my knowledge, really, there's been no quality data that show that any one particular system is quote unquote better than anything else. They all have different indications because an indication is dependent upon a company going to the FDA with a certain data set. And they say, hey, listen, we've done this, therefore we'd like that. And then usually what happens is that one company will get in an indication, or it's a clearance, actually, to use the correct terms here, because it's a device. And then the other companies will say, well, we are substantially equivalent to that other device that you just gave a clearance to, therefore we should also get it. And so that's oftentimes, so there'll be a first group that will get a clearance, and then the other TMS devices will get it later. We saw that, for example, in OCD.
Right.
So TMS is FDA cleared for OCD. That BrainsWay was the first to do it, and then what we found was that MagStim and MagVenture and others then said, well, we're substantially equivalent to this, and therefore you should give us the clearance, and FDA did.
Right.
So it is a complicated system in which to navigate. It is unfortunately the most complicated for the sickest of our patients. And the way that I find it helpful to reframe in my mind is that, this part, advocacy in these situations is one of the things that I can hopefully bring to help.
Yeah.
But I really sympathize with the question. Yeah.
Yeah. I got a couple more questions here. One is from Dr. Chris Anadapa, who's the head of our interventional psychiatry here at SunCloud Health. So Dr. Anadapa says there are a few new approved or popular options for PTSD, including PRISM, EEG, fMRI, as well as psychedelic therapy, especially for our VET TRICARE recipients. Can you compare these neuromodulation options to those for PTSD?
Yeah. So let me unpack that, and Dr. Andadapa, so feel free to chime in on the Q&A there to make sure I've got this right. But so there are a number of different technologies and companies that are often marketing themselves for use in individuals with PTSD, and so often this will include like an EEG based customization or a other system or otherwise, and the simple answer is that approach has never been shown to be any more effective than standard TMS. And if you look at the data that these companies have made, they never compare to standard off-the-shelf TMS. And the reason they don't, you can fill in the blank about why they wouldn't. And certainly if they're trying to sell you something, you should ask them why they haven't, and see what they say. But it's tempting. I mean, I would love to have something where I can put a EEG cap or put someone in an FMR and say, this is your likelihood of response or this and the other. But the truth of the matter is that's just not substantiated by the evidence. And I hope that will be the case, but really those things are research, really best belong in the research space. They're really not ready for clinical prime time.
Great.
And often they're much more expensive, I should say, too. So
yes.
Yeah. I didn't get into the psychedelic things. I should say first, I don't do psychedelic research. It's not because I don't believe in it. It's not because it's just that there's only so many hours in the day. So I think there's a lot of excitement that's in the psychedelic space. I think it's incredibly important to remember that it's very early and we have a lot of money involved in the psychedelic space right now. And one of the core challenges in psychedelics, there's two core challenges. One of which is in the studies that are being done, how adequate is the control condition? Right. And until we can show that we're actually studying the thing we think we're studying, we have to be very careful about our conclusions, extremely careful. And the other thing that adds to that is if the vast majority of individuals who have participated in psychedelic research, the participants have prior experience with psychedelics. And what this means is there's a very, very large selection bias for people who have had positive experiences previously with psychedelics who are in these studies. What we need to see is we need to see psychedelic naive patients in these studies with an adequate control. I mean, subjectively, I think there's promise, but we've not done well in our field previously. I mean, I think there's probably a number of practitioners here who remember when we were, augmenting very heavily with psychostimulants, or aggressive benzodiazepine use. We've as a society really been burned with opiates. We know that ketamine can be, therapeutic effects of ketamine can be blocked with, opiate antagonists. What does that mean? So I do no harm is really high up on my list. And so I just think we all have to be, there's a lot of excitement. I think there's a lot of promise, but we just need to remember where we are at in terms of the literature.
Yeah, I think those are all really great points, especially that selection bias with psychedelics, because on the flip side, the people who have had very bad experiences with psychedelics absolutely would not even consider it, right?
Yeah.
So those aren't the folks showing up in the
and we've seen increases in suicidality in these studies. It's there, and if you go take a look, there's also some reports of malfeasance of the psychotherapists and other people. And when we're talking about people who are, I think about many of my patients who come in with pre-military sexual trauma or military sexual trauma or otherwise. We're really putting people in very, very vulnerable situations. And often, sexuality comes out in these kinds of psychedelic experiences. And so we just again, come back to do no harm. That's organizing. I keep coming back to just be really careful here. Yeah.
Right. Thank you. Great answer to that. Another question, can you share some thoughts about TMS to the ventrolateral prefrontal cortex to affect amygdala?
So Dr. Anandapa has been reading a lot of literature recently.
Yeah.
So that's a great question. So I'm going to unpack what so there's some work out there that shows that if you stimulate really to the side, you can get signal transduction into the amygdala a little bit more directly. That's work in healthy controls. There's actually ongoing clinical trials to see if we can do that in patients. I believe this is stuff that's being done by Desmond Othas and company down at Penn. Big fan of the work. It's ongoing, and we'll find out. And it may be that if we can directly target some of these, these underlying areas, that we'll have better outcomes. And it's stay tuned.
Yeah. Okay. I want to ask another question about the low intensity focused ultrasound studies. It sounds like the trial that you're doing right now, the study that you're doing right now, is mainly on PTSD, or mainly looking at PTSD depression.
Yeah, I mean, it's veterans. So it's individuals with depression. They have to have depression to be in, and they can be plus or minus on anxiety and PTSD and stuff like that.
And presumably substance use.
They can't have any more than mild substance use disorders, if my memory is correct. They can have a little bit, but try not to have too much of that, just because of there's probably some safety concerns that may be in there.
Okay. I mean, just because particularly when you're targeting deeper into the brain, the areas that are more relevant to patients with substance use disorders, eating disorders, there's interest for sure in the eating disorder space. We have very little in the way of treatments for anorexia, adult anorexia nervosa, or atypical anorexia nervosa. Binge eating disorder treatments are, modest in efficacy at best. So if you had to think about, the investigational studies that are going on specifically in the neuromodulation space with regards to promise for, additive benefit in the addiction space or in the eating disorder space, what are you thinking would be, where are you most hopeful?
Yeah, I mean, so there's some folks who are working, trying to modulate the nucleus accumbens directly as well, so that it has direct relevance for eating disorders. It has direct relevance for substance use disorders. Habenula, periaqueductal gray, those are all areas that people are thinking about, and sort of their, the relationship and how close these are to main blood vessels is probably going to be the limiting step. Just remember, because everything's vibrating. So I would say it's exciting, and I think, again, this gives us an opportunity to say, well, where might we want to stimulate where we can't right now, because we're really, we're stuck on the outside of the on the cortex.
Yeah. Okay, great. And before we got started, I asked about the SAINT protocol.
Yeah.
And what are your thoughts on ways to be able to do the neuronavigation piece that are scalable and practical in the real world for people who don't have neuroimaging capacity in their practices?
Yeah, I mean, that's one of the core challenges, the Magnus system, that's the company that's marketing the SAINT device, which you can't buy yet, by the way. It will be coming. Right. That's going to require a quality FMR scan and this, that, and the other. And so that's going to be a challenge. And one of our questions is, there's two questions. One is going to be the targeting, the other which is going to be how much do you actually need? So 10 times a day, right? So that protocol is 10 times a day with a 1 hour skip. And for those of us who have to think about staffing, right, that becomes really challenging. It's really challenging, and for patients too. I mean, so our main questions are, how much do we need to do in terms of the targeting, and how much do we need to do in terms of the stimulation itself? There are some case reports out there, and certainly some protocols that we use off-label with the VA. Where we use the beam F3 targeting. So that's where we sort of measure the skull with a series of anatomical landmarks to find your dorsolateral prefrontal cortex. So we do that, and then our off-label protocol is doing that, and then doing 5 times a day with a 1 hour skip. And that work is published as a case. There was a case series by one of my colleagues, Andy Kozel, who is at University of Florida, who published it sort of in the middle of, it was something he developed in the middle of COVID. Because we would try to minimize the amount of sort of time in chair or people in chair and stuff like that. And it is a protocol that we use off-label in a number of places across the system. And actually, we'll have some sort of work published in that space. The beam F3, sort of the F3 targeting, is very precise. We will have some work that will be coming out in a couple of papers, probably in the coming months, that will show that actually you can get very precise and pretty accurate over time using that in real world patients, which is helpful. So I think that's one of our core challenges in the field. We really do want to make sure that we can bring it. I think there's a lot of promise. The SAINT trial had a really small sample size. I mean, that's 14 people per 13 people per group, and so that has to be replicated, right? We have to. That actually works. The nice thing about this is that again, we're not talking about systemic side effects from extra, like taking more and more meds over the course of a day, right? We're going to run into some immediate problems. We have not yet seen that there's going to be those kinds of problems with accelerated TMS. We should expect that as we increase the stimulation dose on an individual over the course of a day, we should expect to see greater problems with tolerance. We should expect to see a higher seizure risk. We should see a higher risk of maybe like inducement of anxiety. We even if we haven't seen it yet, it's probably because we haven't done enough of it. It's reasonable to expect all those things. That said, right, that side effect profile, right, that's not so bad. Right. I mean, we're not seeing like, massively increased stroke risk from like, an increase in diabetes, in a short. So, it's all a big risk benefit question. Right.
One last very important question. What is wing foiling?
Oh my goodness. What is wing foiling? Yeah. So I should have, I had forgotten I put that in. So that's where you, if you're on imagine a stand-up paddleboard. I actually have a picture of me doing this. I don't have a picture of me doing this.
Are those like the paddle boards that hover above the water?
So it's a paddleboard, and then there's a hydrofoil on a mast underneath. And so you lift up out of the water and you're holding on to what looks like a big butterfly wing that pulls you forward and gives you lift. And the experience is much like flying. And actually what the experience is much like those hoverboards from Back to the Future that we were promised and never materialized.
They never came out.
never came out. So yeah.
Wonderful. Well, I want to thank you again for a really amazing presentation. Also, just for first and foremost being a psychiatrist, and you know, it shows that you really your heart is in helping patients, and I very much respect that and identify with that. And to marry that with the science that you're doing is really special and unique. So very grateful that you took the time to share your work with us today, and amazing work. And thank you again for coming today.
Great. My pleasure. Thank you.
Thank you.
All right. Bye, everyone.